Okay, so this is part two. It's the ulnar and radial nerve. No, pretty much it's the ulnar nerve in this one, actually. See if we can get going on this. The ulnar nerve. So here it is coming down. Key spots as it comes into your elbow. Again, there's just a spot where there's potential entrapment in your elbow around the funny bone. And then again, just as it enters the hand, right around palm side, pinky side, just as it enters the wrist, that tunnel of Guyon, another potential area of entrapment. So we have all these areas in the neck and the pec minor, shoulder, and then the elbow, and then right down by the base of the wrist on the pinky side. This is what the ulnar nerve does. This is how it presents if somebody has damage. It kind of, through long-term compensation, presents what they call claw hand. Somebody has claw hand, think ulnar nerve damage. And kind of their pinky and middle finger are flexed like that, and the rest of their hand is kind of extended. The ulnar nerve is plays a big role in flexing the wrist. Not so much the median nerve, but more the ulnar nerve. Somebody can't flex the wrist, you may think, oh, their ulnar nerve has been damaged. MP flexion of the thumb, they help out with that a little bit. Thumb adduction, adductor pollicis. This is a key functional part of the thumb. Let's think about that for a second. Adducting your thumb, coming up. When we do pretty much anything, I've got this cup here, picking it up. I'm adducting my thumb kind of coming in against my second digit, kind of an adducting opposition kind of thing. To pick anything up, you really have to kind of adduct and opposition and do an opposition to get that firm grasp and that resistance kind of thing. So thumb adduction, huge part of thumb function. It's the role of the ulnar nerve, not the median nerve, the ulnar nerve. Also on the pinky side, the fourth and fifth, the DIP flexion, MP flexion, they help out a lot. Digit abduction, the dorsal interossi, spreading the fingers out, and adduction, bringing the fingers together, and then opposition to that fifth digit. So again, you can see key thumb function is lost without the ulnar nerve. Plays a bigger role than I think people realize. It's not just that median. You really need the ulnar nerve too to have a fully functioning hand. Signs of damage, we talked about the claw hand, difficulty extending digits, hyperextension of the MP joints. Sometimes you see that, especially on the pinky side. Atrophy, especially on the dorsal side, the interossi, you'll get a lot of wasting in there. Wartenberger side, what is that? That's basically your pinky is abducted, kind of stuck out to the side. We'll see that in a second. You can track that with Tinel's. Sims-Weinstein is a good one to check with that. EMGs, we talked about that. Carpal fractures, when people are fracturing their wrist, a lot of times they're damaging their ulnar nerve. Again, the rate of return is very slow. What comes back first? Usually the big flex of the wrist, the FTP, and then as you move into the hand, this is kind of later on. All these different ones kind of come back later on with the hand, with ulnar nerve regeneration. What are the syndromes? You kind of talked about it already. Cubital, not carpal, but cubital tunnel syndrome. Cubital tunnel syndrome. So you look at this woman, hers are plexus. There's her ulnar nerve coming down. Life is good. Life is good. Oh, right in here. Tight space. This is where the syndrome happens. Going right through the elbow joint, through there. Kind of where your funny bone is, right through there. This is it. This is kind of an image of the tight space. Ulnar nerve can be compressed, causing numbness, achiness. Pinky side, coming up through the hand, classically on the pinky side. Used to see a lot of clients that had heart surgery, CABG, coronary artery bypass graft. And when they do that, they sprawl them out like this, and they cut open their chest and then go in and they fix their heart. But a side effect of that, when I would see them as an OT, is they'd say, oh, my hand, ever since the surgery, is not the same. It's all numb, achy, tingling numbness, especially I've noticed on the pinky side. So as the OT, I'm thinking, ooh, I think you did something to your ulnar nerve. As we know, the regeneration is very slow, so it may take this person a year to get their hand back to where it was. A secondary thing to the CABG surgery, because they were just in this position, forcing this kind of compression for a long period, as they did the heart surgery. Here's a splint to kind of prevent the CTS, kind of putting it into a resting position. We'll get into that with the treatment box. The different tests for the ulnar nerve damage. This one's for in specific for the cubital tunnel. Pretty simple. Yeah, I think you know about this one. You just flex your wrist. You just flex your elbow. So you think about it anatomically. You're flexing your elbow. You're putting strain and stress on that compartment down there, that cubital tunnel, causing numbness, tingling. They say, oh, I'm getting tingling, numbness down the pinky side of my hand. Why are you doing that to me? Because I want to see if you have cubital tunnel, because I want to treat it. So that's a test for that. And these are just for ulnar nerve damage, not for cubital tunnel. For ulnar nerve damage, usually somebody has pretty severe, pretty significant ulnar nerve damage, or if they're positive for these. Again, thinking referral to the doc, EMGs, all that sort of stuff. Here's the Wartenberger sign. I talked about it. It just looks like this. They come in and their pinky's always abducted like that. Sometimes they get to the point where they can't bring it back in. They can't abduct it back. Nerve damage to those muscles, and they do that. Here's the ferment sign. What this guy's doing is he's pulling on this piece of paper, and as he pulls on it, this IP joint looks good. This one pops up. Positive potential ulnar nerve damage, positive ferment sign. The tunnel of Guyon, it's kind of the ulnar tunnel syndrome, not as common as cubital tunnel syndrome, but it is. Commonly, what happens is somebody is compressing this part of their hand without realizing it. Like their hand is on a hard desk all day long, and it compresses that, pushes on the little ligament there, pushing, compressing the ulnar nerve, very similar to the whole carpal tunnel kind of thing, causing numbness on the pinky side and achiness and weakness. There's the Guyon canal, tunnel of Guyon, the ulnar nerve right through there, tight space. Again, it fits our theme with the tight space. There's the ulnar nerve distribution. Also, a lot of the blood flow, 6% of the blood flow of the hand flows through the ulnar artery, through the tunnel of Guyon. So if they're pinching and compressing this, it could lead to all kinds of problems. I think this is the hyperthenar right there, could lead to atrophy there because they're not getting the blood flow they need, losing the nerve damage, not getting the ulnar nerve in there. So it's a bad thing if that's starting to get compressed. We're going to address that right off the bat. Okay, this is a cool little activity that we do in class usually, but we don't have a class because of COVID. We have to do everything in the lab. So let's see if you can do this on your own. I would do this on your own. Why am I torturing you with this? Because it's very important to get these nerves down, the damage down, what you can do, what you can't do with or without a particular nerve. For this class, for the final exam, and again, for the board exam. And your clinicals over the summer if you're dealing with these kinds of issues. So the question is this. Let's say they've lost, let's do it like this. Let's say they've lost a median nerve. If they've lost a median nerve, can they do this task? Can they bring a Cheerios to their hand, manipulate Cheerios in their hand, write, use a spoon, cut? Can they do that without the median nerve? Let's think about that. Okay, so now we're thinking, everybody thinking, what happens if I lose my median nerve and I try these tasks? Okay, time to stop thinking. Let's talk about it. All right, so you've lost the median nerve, so you cannot flex, remember that second and third digit. You can't really flex the thumb much either. So all you've really got for use is your pinky and your middle finger. So you got your pinky and your middle finger. Can you pick up Cheerios with your pinky and middle finger? Maybe. I don't think so. Pretty difficult. Can you translate them in your palm? Don't think so. Can you write? Probably. Not very well, but you probably could write to a degree. Can you manipulate with a spoon? Probably. Very, very difficult. Can you cut with a knife? Real difficult. Difficult to impossible. Definitely going to severely impair you with these basic things if you've lost your median nerve. Now let's flip it around. You've got your median nerve, but you've lost your ulnar nerve. So you've got the second and third going pretty well, but remember, you cannot adduct your thumb. You cannot do opposition to the fifth finger. Can't adduct your thumb. Can you write without adducting your thumb? Thinking. Probably hard to do, not impossible. Can you hold a spoon without adducting your thumb? Not the way you usually do, that's for sure. Cut. Very, very difficult. Pick up a Cheerios. Probably very, very difficult. So both these nerves are just huge deals. Functionally, that's the bottom line with your hand. Think about these, apply these, ask questions about these. It's not coming to you how this impairs your function so severely, because you're going to get questions on these, little tedious, mind-numbing questions on these potentially on the final exam. There's a little task we do. We do these tasks in class. COVID. Okay, so this is something else you're going to get in the final exam. You're going to get this image of this lady, and you have to try to color in the nerves and mark off where they're getting pinched and impinged. So let's do it together. This is just for the median and the ulnar. Let's do the ulnar first. Where does it potentially get impinged? We know it gets impinged TOS, right? Scalenes, right there. Clavicle, right there is a second spot. Pec minor, right there, there's a third spot. 1, 2, 3. Following the ulnar nerve, coming down, coming down, coming down. Through the elbow. Through the funny bone. Potential fourth spot of entrapment coming down through. Where all that space and flow stuff will happen. And we'll get numbness and potential problems. And then the fifth spot, what is the fifth spot? Say it. Tunnel of Guyon. So we have tunnel of Guyon 1, cubital tunnel 2, pec minor 3, clavicle first rib 4, scalenes 5. So you would draw this, just like I draw a line down through this image. I think we might do this in the lab, and then put an X, an X there, there. And then the median nerve, similar kind of deal, initially those 3. And then coming up through here, through that Struthers ligament, PTS. This is the new one, I think, for most of you. Pernatuary syndrome. Here's the fourth potential spot for the median nerve. And then the fifth, we all know, carpal tunnel. So these are what you need to know for the median nerve. Okay, so let's wrap this up.